Welcome to the April 2014 Connell Seminar Series as we bring you the latest healthcare reform updates with attorney Andrew Haynes. Opening the seminar is Connell Insurance partner Randall Gamble, followed by Tom Jensen's introduction of our speaker.
Good morning, folks. I want to introduce first Tom Jensen, and then Tom is going to introduce our speaker. And Tom came to us last September. He started with us. Our previous life and health department is what we've always referred to it. We now try to refer to it as group benefits. That's what our real focus is. We're a commercial insurance agency, as most of you know. We are in the stages right now of opening a Springfield office, but clearly we are focused on business and commercial insurance and employee benefits. And we brought Tom on board last September. He has a strong background, 10 years plus, in employee benefits, and he's somewhat like me, but he's a strong technician. He has a strong interest in it. Most of you that do know me know I'm kind of a work comp nerd. I think of him as the employee benefits nerd. But the key thing with this is we are trying to grow our department, grow this segment of our business, and the main way to do that is to provide our clients and prospective clients educational opportunities to keep you updated on changes. But Tom came to us. He's doing a great job. We've added new staff, adding more new staff as the days progress. So he's the new kid on the block. And with no further ado, here is Mr. Tom Jensen.
My name is Tom Jensen. I've been with the agency now for about 7 months, and it has been a kind of a wonderful experience coming from the health system and really coming over to the agency side and bringing that experience with me. So most of you I've met at one point. Those of you I haven't, at break, I'd love to visit with you and give you a card, try to find a time when we can come out and sit down and have a visit. But I'll keep my part short and kind of get to Andy. I've had the opportunity of working with Andy now for about 5 months, and he's been working with the agency for several years before that, doing presentations and such. And one of the things that we identified that we need to bring that expertise to our clients, and one of the first things that I did after joining the agency was look to strengthen our relationship with Mr. Haynes. And one of the resources that he provides us is the compliance piece that we need to provide you. So if you haven't seen it already, we'll be sending out to those that are on our email list, we'll be sending out a kind of a compliance update. And it's not something that comes out every week or every other week or every month specifically, but it comes out when there's information you need to know. So we get the information from Haynes Benefits Group, and then we in turn will push that out to our clients as well. So we feel that's a great resource, and it helps us keep you in the know and compliant as well. So with that, I will read your bio because I don't want to mess it up. Mr. Haynes is the president of Haynes Benefits PC, an employee benefits law firm in Kansas City. Andy has led over 150 seminars and media events regarding healthcare reform to various private and public sector audiences. Andy is the current author of 2 books published by the Employee Benefits Institute of America. The first one, HIPAA Portability, Privacy, and Security, and the second, Group Health Plans, Federal Mandates Other than COBRA and HIPAA. Known as the singing benefits lawyer, Andy's seminars combine his passion for benefits law and music in a unique manner, creating informative and entertaining seminars. Andy is a lecturer with EBIA and other prominent employee benefits organizations, teaching in numerous cities each year. Andy received his undergraduate degree from the University of Missouri-Columbia and his law degree from Emory University School of Law, where he was a research editor of the Emory Law Journal. An active member of the community, Andy and his family reside in Blue Springs, Missouri. He is an active musician in his church band and the occasional gig. He is active with local PBS and NPR stations as well, where he serves as an on-air personality. It's my pleasure to welcome Mr. Haynes.
I appreciate Connell bringing me in again. I enjoy the opportunity to be with you all. I enjoy coming back down. Previously, I've done these in Branson, and it's neat to be here in Springfield today. I was actually born in Springfield. We lived in Humansville at the time, and you are like the only people in the world who know where Humansville is. But we lived there, and I was born down here. My grandmother lived here up until just several years back, and you probably know where she lived. She had an old house near the MSU campus. It was on Elm Street across from the Get and Go. And one of my favorite things as a kid was when I visited her, I got money to go to Get and Go and get candy. I mean, didn't get any better than that. Where her house was is now a parking lot that the university bought it. But one of the things that I think kept her young was she took this big old house and divided it into 4 apartments, lived in one, and rented the other 3 apartments out to college students. And I truly think that helped keep her young. And the college students liked her because she was over 21 and they weren't, and I'll let you figure the rest of that out. And when Tom and I were talking about where to stay, he mentioned a place. He said, it's near downtown. I said, I remember coming to Springfield and visiting Grandma, and every time we would go to the Hers department store downtown, that was such a store, we would come visit Grandma, and she'd want to go to Hers and buy a girdle. Now, I could never figure out why every time we came to town, she needed a new girdle, and was it, why was she gracing us with that? But she indeed was, so lots and lots of fond memories of Springfield. I'm going to talk about healthcare reform. This has been my life for the last 5 years, leading up to the date that the Affordable Care Act was signed into law. But it's been my life, and it's been an extremely interesting period. I've been in practice for 30 years. I have this firm now, which we call Haynes Benefits, which I set up slightly over 10 years ago. We're celebrating our 10th anniversary this year. We started with myself and an attorney who was working about half-time, who came with me from my prior firm. In those 10 years, we've grown from 1.5 attorneys to 7 attorneys. A lot of that growth is directly attributable to healthcare reform. We just have had so much to do. We've enjoyed the relationship with Connell, providing information to the people you work with, and assisting with some of the compliance issues, some of the complex planning issues. And so we have very much of a partnership between the 2 agencies. All right, what are we going to talk about? I'm going to start off with a market overview of some of the provisions that are already in place, some that are going into effect this year, 2014, and some that are going into effect down the road. Second, we're going to talk about that immensely successful program called the Exchange. I thought that'd get a little bigger laugh than that. But we're going to talk about the exchanges and what they've done to the market, a little bit about where they are. We'll then get into pay or play, which in our firm, and one of the handouts Tim and Tom have sent out, is our article we wrote on it, which our new title is Pay, Play, or Delay. And so we'll be hitting that in quite a bit of detail. One of the things as we go through that section, and when I do my talks, I always like to start off with policy and economics, because those are what create the rules we have. And so if you don't understand the policy and the economics, then the rule won't make sense. The pay or play rules are just complex for the sake of complexity. And so they're a very tough topic to cover. I'm allotting about an hour, a little over an hour to them today, and that's not nearly enough time. I've done 2-hour webinars, 3-hour webinars and such, just on pay or play. But we'll get through that. The one thing there is, and Tom talked about questions, kind of hold your questions to the end of that section. It's a weird section because there are a whole bunch of rules, and you may have some questions right at the front end that I'll actually get to as we go through those rules. And it's a tough topic to cover linearly, but we'll give it a try. After that, you need something more fun, so we'll talk about sex. That's also to assure you come back after the break. And then finally, we'll talk about HIPAA. HIPAA is not really healthcare reform. It's certainly not Affordable Care Act, but it is extraordinarily important. And part of the reason it's so extraordinarily important is that in the last 18 months, for the first time since HIPAA was passed in '97, the government has now got over 1,000 auditors on the street looking at HIPAA compliance. And they are issuing very scary penalties for very minor violations. And we'll go through that at the end. And so that's kind of an overview of what we're going to do today. Let me just kind of set the stage. And these next couple of slides I've actually used before with y'all, but I just want to set the stage on where we are. First off, when the ACA, or we sometimes call it PPACA, Affordable Care Act, Healthcare Reform, or your own terms you use for it, came into law, I had a number of clients who would come in with one or two kind of ideologies. Some of them wanted to come in and talk to me about it and gripe. And not really realizing that I was charging them to sit and gripe to me. Last week I spoke with a medical panel at a presentation. They said, I think that's called therapy. So I do that. Others came in and said, like Connell, we want to find a way to distance ourselves from the competition and look at this and say, what are the market opportunities for us as an agency and for our clients as employers? And one of the things that we've really seen, if people took that attitude, they're well positioned right now. Because the vast majority of the folks are just complaining and not working on it and are now behind the curve. But we've been from the front end looking at what are the opportunities. So anyway, for those complainers, I realize that for other kind of addictions or abnormal behavior, there are a lot of 12-step programs. So I came up with a 3-step program on the Affordable Care Act. The 3 steps are, it was bound to happen, number 1. Number 2, it did happen. Number 3, deal with it. Okay? Now, I'm going to have you repeat these after me because it will make you feel better. All right? It was bound to happen.
It was bound to happen.
It did happen.
It did happen.
Deal with it.
Deal with it.
All right, you feel kind of cathartic? Was that better? So that's my 3-step program, and it just is what it is. And it's very interesting because in Washington, even the opposition party to the White House, the Republicans, have finally realized, at least privately, that repeal in place has no chance. This law is here. It's going to be tweaked and delayed and fixed and amended and all that, but the base of this law is here to stay. And the polls are coming out showing gradually increasing support for it. So we've had a couple of key developments there. Speaker Boehner made a comment to his Republican delegation, stop talking about repeal and replace, because we can't do it. Let's not promise something we can't do. And I think the most interesting development came about 2 weeks ago. The U.S. Chamber of Commerce, the epitome of an industry for small business, said, let's talk about fixing it, not repealing it. That's an enormous step that the chamber would do that. So that's kind of where we are right now. So what about this bill and when it first came out? The Kansas City Star did an article on Secretary Sebelius. You know, one of the interesting things that we have here in Missouri is very direct ties with the 2 most key people in enforcing the Affordable Care Act. Number 1 is Secretary Sebelius, who, prior to being Secretary of HHS, was governor of Kansas, and before that, she was a commissioner of insurance in Kansas. And she's the one most directly responsible for enforcing this law. The second most important person was Jay Angoff. And Jay Angoff was Commissioner of Insurance in Missouri, while Secretary Sebelius was Commissioner of Insurance in Kansas. So number 1 and number 2 people are from our area, which gave us a lot of direct input, which was very helpful. One of the things the Star article did was look at the statute itself and looked for 3 words: the Secretary shall. The Secretary shall. And that means Secretary of HHS. That appeared 1,300 times, meaning that when this law was passed in 2010, there were 1,300 new items on Secretary Sebelius's to-do list. Some of them were file reports, some of them were to study issues, some of them were to issue regs. When this article came out in 2010, she estimated there would be between 30 and 50,000 pages of regs when all was said and done. We're getting very close right now to that 30,000 page number, and we're nowhere near there yet. In the past few weeks, we've been getting about 500 pages a week in regs, and that's why I'm buying new glasses about every few months. It's been extremely challenging to stay on top of it. The agency, and Sebelius herself, also came out and said, this is a little more difficult than we thought at the beginning. Yeah, think? And so Sebelius said, this is the reason for some of the delays. It's challenging for HHS, and it's also challenging for employers and individuals. So for those reasons, we're seeing a lot of delays. How should you, and I want to do this at the beginning, I used to do this at the end, but how should you stay up to date on the ACA? We're obviously providing a lot of information to Connell. And what I find is, in the market, there are 2 things. Number 1, a lot of people have too much information or too little information. You know, for a while there, we do our own email alerts, and I was getting 30 or more a day. And, well, hey, I like reading this stuff, but I'm really weird. So, you can get too much by getting it from a number of sources. You can actually get too little. One of the things I also say is, if you're getting all your information on the ACA from Fox News, you're not getting the whole story. If you get all your information from MSNBC News, you're not getting the whole story. Don't get it from journalists. Get it from benefits professionals. It drives me crazy to watch TV news when they talk about the ACA. It absolutely drives me crazy. My wife refuses to be in the room when they're talking about it, and I sit in my chair and groan. Oh, no, that's not right. She hates it. So work with professionals on getting this. Again, we're supplying a lot of information to Connell. We have our own website. What I really recommend, find 2 or 3 sources you really trust and stay with them. It can be that you get so much information that you just can't read it all. So let people you trust filter that down and give you what you need to know. Now, it was late on a weekend night, and I was in my office working on PPACA. I decided that our firm needed a mascot for healthcare reform. So, since it's PPACA, who would be a better mascot than an alpaca? And so this is Patty, the alpaca, who helps us with PPACA. If you go to our website, Patty's all over it. We send out emails. Patty's birthday happens to be March 23rd, which is the date the Affordable Care Act was signed into law. She shares the same birthday. She's 4 years old this past month. And if you go to our website, there's all sorts of stuff about Patty the alpaca. Yes, I have gone over the edge on healthcare reform. All right, let's look at the market overview. Here are some rules that are already in play in the period between 2010 and 2013, just to lay the foundation. You already know most of these, if not all of them. But let's just do a little reminiscing. Dependents can now be covered up to age 26 on their parents' plan. even if they're married, even if they're in a domestic partnership or a civil union, or if they're unmarried, if they're making money, if they're a deadbeat, doesn't matter. The old rules would say, well, we have to look at the level of support. Who's providing the support, the parent or the kid? Doesn't matter. Under the ACA, the only thing that matters is, are they a child of the participant? Okay? Number 2, no lifetime limits on essential health benefits. When I first started practicing, most plans had like $1 million limit, total lifetime limit. Over time, it went up to 2 million, 3 million. Later, some did 5 million. But as of 2010, no lifetime limits on EHB, essential health benefits. Number 3, restricted annual limits on EHB. So a plan couldn't say, well, we don't have a lifetime limit, but the limit will be $100,000 per year on essential health benefits. And that's not permitted either. Number 4, no, that's supposed to be rescissions, not recessions. I just saw that. No rescissions. And what that is, a rescission is a termination of someone retroactively. They're on the plan, but for some reason or another, the employer wants to terminate them back to January 1, a retroactive termination. And rescissions are extremely frowned upon in the ACA. So no rescissions under the ACA. The one everybody knows about, no pre-ex for those under the age of 19. If you look at the various provisions in the public surveys, there are a few parts of PPACA that everybody likes, only a few, but there are some. And the pre-ex rule is one of those. Most people don't want pre-ex conditions, and particularly for their kids. I happen to have, my youngest is a type 1 diabetic. No carrier in the country wants to insure her. She's going to be extremely expensive the rest of her life. And like many parents, I want to make sure she's okay. The rule for age 19 and age 26 is very critical if you have a child who has a chronic health condition. The final one on this page is coverage of preventive services. This is an interesting one because this really did change the market. Prior to the ACA, employers in the small group market really didn't get first dollar preventive coverage or first dollar wellness benefits. And the reason was that when you pay for wellness benefits, it typically takes 5, 6, or 7 years for you to get a return on your investment. Carriers know that small employers change carriers every 3 years. So they're simply saying, why are we going to pay for something that doesn't even start paying off until after they leave? So some other carrier is going to get the benefit of what we put in place. So one of the goals of the ACA was to require certain preventive services to be covered for all plans. And this is one of those rules that a lot of people like. And the idea is, even if you change carriers, you get these covered. And the carriers can say, we're willing to do it now because even if we lose people after 3 years, we'll be gaining other people who've had that same thing, and the investment in the market is worth it. Now, I spoke at a meeting that some of you were at yesterday. I want to say that list of preventive services is better than what the small group market got in a lot of areas, but it's still not nearly enough to be a truly outstanding wellness program. And in my mind's eye, in doing plan design, one of the key features for the next few years ahead is an absolute state-of-the-art wellness program. And so I think that's something that if you don't have already, you should be looking at in a lot of detail. Next, we have several rules relating to how and when an employee or an insured can get access to services. One of those is it allows the employee to choose the provider they want. Several of those include such things as you don't have to get a referral to get your child to a pediatrician. The pediatrician can be the primary care physician. Same is true for an OBGYN for women. Emergency services. There are some provisions in PPACA that I look at and say, why'd they bother? The market's already doing this, and emergency is one of them. And what it says is if you're out of network, but you have an emergency, and you go to the emergency room, you know, one thing's in our family, we have 3 kids who are all now grown. My youngest is in college. But it just became a standard deal in our house. One of the things we do on vacation is go to an emergency room. Does anyone else have kids like that? I mean, every year, our vacations in Branson, we got to know Skaggs real well. We always had to go to emergency room. Well, in Florida, that's out of network, but the rule says, well, even if it's out of network, if it's an emergency, it's covered at an in-network rate. Okay, everybody was doing that already anyway. I didn't know of any policies that weren't like that, but it's there, and it's absolutely forcing us to do what we were already doing. Okay? SBCs. These are summaries of benefits and coverages. In most situations, you have a plan document and a summary plan document. In a fully insured plan, you have a policy and a wrap, at least you should. And either the SPD or the wrap summarizes the other policy. Well, the SBC is a summary of the summary. And the SBCs, the way this rule came down was hilarious. Okay? The rule said that the SBC has to be published, and you have to do it in 2 pages. Now, the problem was the list and the statute, everything that had to be on the SBC was more than 2 pages long. So you couldn't fit all the stuff on the SBC. And so HHS was supposed to come out with a Form SBC, and they kept delaying. We know what's going on. You can't do it. It won't fit. Well, they finally came out with it. And they said we got it to fit within 2 pages. But what they did was defined the word page. And a page is a sheet of paper. A sheet of paper is not 2 pages, you know, front and back. A sheet of page is a sheet, and a sheet means a page. So 2 pages meant 2 fronts and 2 backs. They were also supposed to do a glossary, and they decided that didn't count in the limit. So they got a few more pages for that. So the 2-page SBC became 8 pages. And, you know, we knew it was going to have something had to happen, so it had to redefine page. And it's kind of like what your definition of is. It's a page is a sheet of paper. Also from 2010, we have new appeals rules and external review rules for an independent external review agency to overlook any adverse benefit selection. New limits on flexible spending accounts and cafeteria plans. We'll get to those later. No over-the-counter drug reimbursements through FSAs. That was a revenue measure. New W-2 reporting. That one, remember all the controversy that created a couple years back when W-2 reporting came into the complete discussion? Everybody thought that meant that their benefits were taxable. They're not taxable. They're simply reportable. And then MLR, medical loss ratios, which meant that carriers had to spend at least 85 cents of every dollar received in premium on actual claims. And if they don't, then employers and employees are entitled to some money back through a rebate. Anyway, you know those. That's just to kind of get us started. Now let's look at what's come into play over the 2013-2014 period. The first is what we call PCOR fees, or PCORI, which is patient-centered outcome research. Patient-centered outcome research. This is a program that's part of the ACA where HHS is supposed to study different treatments for a condition and look to see which are the most efficacious and efficient, so that potentially that will help in defining what a plan has to pay for. Well, to do this study is a cost, and the fees for under PCORI went into being July 31 of last year. When the first fee was due, the second fee is due July 31 of this year. It applies to carriers, it applies to self-funded plans. So that is the PCOR or PCORI fees. PCORI is Patient-Centered Outcome Research Initiative, which is actually the full title. As we go through the morning, you're going to see a number of these charges and additional fees that are a part of the ACA. Okay, let's look at 2014 now. What rules are kicking in now unless they've been delayed? Number one is, for 2010, no pre-X for those under the age of 19. For this year, no pre-X for anyone. No pre-X for anybody. One of the corollaries of that rule now is that HIPAA certificates are no longer going to be required, it looks like. Number two, no annual limits on essential health benefits. Cannot have annual limits on these essential health benefits. This attacks what we call mini-med plans or skinny plans or other plans like that. When we get into pay or play, I'm going to talk about skinny plans. I've been in the media a fair amount on that issue the past couple of years. Number three, we got some new cost-sharing limits. The out-of-pocket cannot exceed the HSA limits, which for 2014 is $6,350 for employee only and $12,700 for family. So the out-of-pocket limits on a plan cannot exceed $6,350 for an employee. These new rules are delayed, and you're going to hear that word a lot this morning, delay and delayed. But these rules have been delayed where a plan has the medical benefit and the prescription benefit provided by different carriers. So just as an example, the plan might be a Blue Cross plan with an Express Scripts RX instead of the Blue Cross RX. And so those two carriers have not coordinated their software so that Blue Cross doesn't know what Express Scripts is paid and vice versa. So we received a delay to allow the carriers and the prescription drug PBMs to get their software together to match up, and it's delayed while that's taking place. The delay only applies if the RX and the medical benefits come from different carriers. If you've got both your medical and your RX through Blue Cross or any other carrier, it doesn't apply because Blue Cross can talk to itself, even though it might not be able to talk to some of the other RX carriers. Wellness incentive limits increase. These are up to, it was 20% prior to this year, and this year the wellness incentive can be 30%, or if smoking cessation or anti-tobacco program is involved, the incentive can now be 50%. Only if there's a tobacco component to the wellness program. In any event, it goes up from 20 to at least 30, and in some cases, 50%. Deductible limits. Let me tell you a little bit about what my life is like right now. Tom was talking to our staff, and as most people who had me come speak said, you know, when can you get these slides to us? Get us to us a couple weeks in advance, it'd be great. I kind of laughed. I said, I'll get them to you like the day before. And the reason is, if I'd given you these slides 2 weeks ago, they'd be so out of date. Okay? I ended up, my staff ended up sending them to Tom and Dave Wednesday evening. So they've had these slides in their hands for about 30 hours. We sent them out, I don't know what time it was, 6:30 Wednesday evening, something like that. By the next morning, these were out of date with the rapidity of changes. And this is one of those rules. The new rule, or the rule for 2014, is the deductible limits are $2,000 single and $4,000 family. That's the maximum deductible on plans sold in the small group market. As of Thursday, that rule has been delayed for a year. So those limits do not apply into the small group market for this year. It's been delayed by 1 year. We'll see if it's delayed further. One of the questions I always get is, what does small group mean? The answer is, depends on which rule you're talking about. Under PPACA, or the ACA, there are 4 different definitions of a small group. Well, why did that happen? Well, let's talk a little bit about how PPACA was written. It wasn't one woman sitting in her office writing 2,700 pages of statute. This was written by Congress, and it was written by different committees in the White House and in Congress and the Senate. One of the things that makes what we do so challenging is, like here, small group has 4 different meanings depending on what rule you're talking about. The 4 different definitions are 25, 50, 100, and 200. So depending on the rule, small group might mean 25 under small business tax credits, or 200 under the automatic enrollment rules. For most rules, it's in the 50 to 100 range. I was doing one of my EBIA presentations, and a woman right in the front row, which, by the way, the front row is kind of barren up here, this woman raised her hand and said, "Who wrote this thing?" I said, "It's not who wrote it, it's how many wrote it." Because different committees, and so we'll have, like small group, we will have words where a same word will have different meanings in different parts of the statute. And we'll also have the same meaning that will be defined by a word that are different words in the statute. It makes it very difficult to go through. But that's the deductible limit. You might put a note there. That has been delayed for at least 1 year to 2015. Clinical trial coverage. This is a very expensive rule. A lot of plans only wanted to cover procedures that are fully and finally approved by the FDA. Some states started saying, and the FDA process is phase 1. If you're successful, you go to phase 2. If you're successful, you go to phase 3. If you're successful, you go to phase 4, and then full and final approval. Some states would say, well, you have to cover at least phase 4. Some would say you have to cover at least phase 3. The courts at the federal level, the landmark case in this area actually came out of St. Louis as a case called Henderson versus Moline Aluminum. And the court said, and in that case we had a woman with breast cancer who was going to die. Every procedure that was fully and finally approved had been tried. None of them worked. And she wanted a procedure that was in the clinical trial setting. And the carrier refused to pay for it because the plan said only full and final approved. You know she's going to win it, right? What court's going to say, no, I'd rather let you die? Well, she did win. And so we saw that coming. The clinical trial coverage is in the ACA, but it's not a new concept. What it says is this, that the plan has to pay, and this is really boiling it down, the plan cannot deny coverage because it's in a clinical trial. And that goes all the way down to phase 1. The plan has to pay for the procedure, but it doesn't have to pay for the trial. See that? The plan, if it's a procedure for breast cancer, the plan would have to pay for the chemotherapy in the phase 3 trial, but it doesn't have to pay for the research part of that, okay? And it creates a very interesting scenario. Prior to ACA, we dealt with a lot of clinical trial appeals. And a lot of my plans tend to be pretty generous of the clients I have, and they want to cover certain things. But as you think about what a clinical trial is, most of these clinical trials are double blinds, meaning that half the patients are getting the therapy and the other half are getting sugar pills or saline water in the IV. They're not actually getting treatment. Prior to the ACA, when we would have these and the client would say, well, we want to pay for it, we would go to the research folks and say, we'll pay for it, but only if you guarantee that our patient, our employee or dependent will actually get treatment and not just the placebo. So we'll pay for it, but in essence, you have to take it out of the trial because it's no longer a double-blind trial. One of the things that bothers me in this rule, that option isn't there. That option is not in the rules that say, you can say, we will pay for it as long as they're actually receiving the treatment. You with me on that? Okay? So that's something we're kind of going to watch and see how it plays out. Next rule are waiting period limitations. For certain employers, and we're going to talk more about this as we go along, this rule, this key number, 90 days, is going to show up about a dozen times in the slides I have to go over today. ACA says no one should wait more than 90 days to be on the plan. And you're going to see that throughout a lot of stuff. So the maximum waiting period for an eligible employee will be 90 days. The coverage must begin on the 91st day. Because of this rule, if you're an employer to whom this applies, I want you to look at your eligibility language. Because a lot of us said before 2014, an employee is eligible for coverage on the first day of the month following what? 90 days of employment. Okay? So if they came to work on January 1, what day would they come on the plan? Excuse me, on January 15, what day would they come on the plan? First day of the month following 90 days. So you go February 1, or February 15, March 15, April 15th, and they're eligible May 1, right? First day of the month following 90 days of coverage. You can no longer say that. This rule says 90 days means 90 days. If the person's hired January 15th, they're eligible April 15th, not May 1. If you only allow new employees on the plan on the first day of the month, you now need to say first day of the month following what? 60 days, not 90 days. Okay? First of the month following 90 is not permitted for most employers under the statute now. That is a big deal. When the regs came out, the regs looked at how this affects rehired employees. Rehired employees really cause a lot of problems and benefits. I mean, how does this rule fit in? How does pay or play fit in? Are they a new employee? Are they a rehired employee? Have they always been an employee? We've always had these issues on the pension side of benefits. It's been there forever. It started seeping in on the health side, but with this rule now, it's even more problematic on the health side, this whole concept of rehired employees. There is only one way I know of to get rid of this issue. Never, ever rehire an employee. And then you don't have to deal with all these issues. If you do rehire employees, or if you do rehire a block of employees, then you really need to look at a lot of the rules relating to that. A lot of these rules look at how long was the employee gone, what was their status, what was their job title, what does the personnel manual say, and in many cases, when they're rehired, there cannot be a new 90-day waiting period. They have to come on immediately, okay? Next rule is auto-enrollment for large employers. This rule, well, first, how many of you here are in HR and benefits from your companies? That's what I thought, nearly all of you, okay? How many of you also do your firm's pension plans in addition to your health plans? Most of you, okay? The concept of automatic enrollment is not new on the pension side. It's been around for a long time. And the reason it was there particularly was with 401k plans, because a lot of employers had trouble meeting the non-discrimination rules for 401k plans because not enough low-paid employees were electing onto the plan. So the employer would say, we're going to do automatic enrollment or negative enrollment, meaning you're on the plan unless you opt out of the plan, and that's to help meet the non-discrimination rules on the 401k statute. This new auto-enrollment rule does the same thing on the health side. For large employers, here being defined as 200 employees, more than 200 employees, those employees will be on the plan unless they opt out. So they're automatically on the plan unless they opt out. This rule was supposed to go into effect this year. It has been delayed. Not really, there's not been a statement that it's been delayed. The statement is we will not enforce the rule until we publish regs, and we're really busy and we won't publish regs in 2014. So that's effectively a delay, okay? But this rule for larger employers is dramatically going to affect how you do your business. We also have new rules on an annual fee on health insurers. It applies to carriers, it applies to self-funded MEWAs, and it applies to self-funded group health plans. And it's an annual fee on health insurers. It's there to help pay for some of the costs of PPACA, and just something that we'll be dealing with, and that is being collected. Next rule. My next 2 pages are going to talk about some concepts of the financial underpinnings of the market. And the thing I find incredibly fascinating is, to me, these are some of the most important rules in the entire statute, if not the most effective rules in terms of what effect they have on pieces in the entire statute. And what's really weird to me is that nobody's really talking about them. I want to go over those in some detail. Now, here's my disclaimer. A few of you were here for a talk I did yesterday, and I said yesterday I will be repeating about 2 slides tomorrow. These are those slides. So if you were here yesterday, this is a great time to refill your coffee. Okay, the first one in the statute is called FHIP, or Fair Health Insurance Premium. Those of us in the market actually put a different name on this, and we call it Adjusted Community Rating. This applies to the small group market. The FHIP, or ACR, Fair Health Insurance Premium, or Adjusted Community Rating, says that those factors which carriers have used to price an employer's plan will have to be scaled down to only 4 factors. Those 4 factors, being the only factors a plan can use, are age, geographic area — Springfield is a different cost than St. Louis, which is different from Kansas City — status, meaning single, married, family, and tobacco usage. Okay? No other factor can be used. On the age bands, Tom, in this area, how many bands did most carriers have prior to ACA? Would it be more like 5, 6, 7?
Yeah, I think, and we can, Bart, 7, is it? Quite a few, 7, 8, so
Yeah.
there's quite a few.
As of now, only 4. And if you look at the age band, look at those bands. Under 21, 21 to 63. Yeah, there is no difference in the health status of a 21-year-old and a 61-year-old. They're going to be paying the same rate. You know, you actually get healthier, right, as you get older. And then adults age 64 and older. So under 21, 21 to 63, and 64 and older. So in the past, there might have been 7, 8. Some places I've seen that number, even maybe a few more. Remember, it used to be like individual, individual plus spouse, individual plus child, plus 2 children, plus family. Okay? Other factors go away. One of the most important factors I've always thought was what percentage of the employees are on the plan. If 100% of the employees are on the plan, the rate should be less than if 50% are. Because if 50% are on the plan, what does that mean? That's adverse selection. The only employees who are going on the plans are the ones who know they really need it. Can't use that factor anymore. Industry. What industry do they come from? Some industries are terrible risk. One of the most terrible risks is my industry. Lawyers are horrible. We have one of the highest adverse claims experience of any groups. Why? Because lawyers aren't nice people. Anytime a carrier denies a claim on a lawyer, we argue about it. Lawyers also have a lot of stress-related illnesses, and lawyers have an extremely high rate of alcoholism. Okay? So lawyers are in that real bad band of, we really don't want to cover you. Just to give you an idea, we hear most industries are seeing a rise in rates because of adjusted community rating. Our rates at our law firm went down 35% because we're in such a bad category. We call this adjusted community rating because what it means is all other rates are brought together. And so these are only 4 factors that can be used so that the rates for the community will be much, much more uniform. The premium review process. Either the state or the feds can review an increase if they deem it to be unreasonable. And I love this language. If the rate is unreasonable, then the plan has to prove that it's reasonable. What? You've already cited it's unreasonable, but you have to prove that the rate increase is reasonable. So they defined unreasonable to be 10% or more. So if the rate is more than 10% of an increase, the plan has to prove, or the carrier has to prove, that that increase is reasonable. This does not apply in the large group market. A lot of the rules we'll see are that way. Transparency, this means that all the carriers are going to have to put their financial statements on their website. Like employers really want to read that. There are 3 other rules I want to talk about, and before we get to another set of 3. But the next 3 are called guaranteed availability, guaranteed renewability, and single risk pool. GA means that if a carrier offers a product in the small group market, and by the way, most of when I say small group, most of these rules also apply to individual policies. But you all are here because you work for an employer and you're in HR, so I'm not going to talk about the individual market. But most of the time that I say small group, it also means individual. So GA means If a carrier is offering a product in the small group market, it has to offer it to every small employer in that market. It can't say we want to offer that product to your firm, Arlene, because you've got a really good risk, and we don't want to offer it to Andy's group because, well, they're lawyers. Okay? So guaranteed availability means it's available for everyone. Guaranteed renewability means once a carrier covers you, they have to renew you. They can't say, we don't like you anymore, unless there's been something like claim fraud. The final rule is called single risk pool rule. And Congress thought that carriers and plans might try to cheat the system. I'm so offended. But what they said was, well, we're going to have these exchanges, and what we don't want to have happen is that a carrier might come to Opal and say, we really like your group, and you're very profitable for us. And so we want you to be in our non-exchange plan. We want you to be in our private plan side, okay? Not on the plans that we do on the exchange. Whereas Arlene's group now is an unhealthy group, and the carrier would say, tell you what, why don't you go on to the exchange? Because if you go on the exchange, we'll get some subsidies from the government to help pay for your bad claims, all right? So Congress thought, well, the carriers are going to adversely select against the exchange plans, knowing that there will be some of these rules we'll be talking about to subsidize that adverse selection. What the single risk pool rule says is this. If a carrier is offering a product in the exchange market, it has to pool its exchange and non-exchange business. You get that? What that means is, even if your employees aren't in the exchange, they're still going to be affected by the exchange experience because their risk will be pooled between the exchange and non-exchange. So that's a very, very key rule. These are the three, what I call the 3 R's: reinsurance, risk corridors, and risk adjustment. These rules are very complex, but they do something pretty simple. And we just got a whole bunch of regs. The reg projects on those 3 rules, I don't know, probably 500 or 600 pages. These rules say some carriers, because of their name and people wanting to be with that carrier, get the best business in the state. True? I mean, some carriers are able to really say, you know, we got so many people wanting to use this, we're only going to take certain employers because those are ones that will be profitable for us. Other carriers are left behind to pick up the pieces, and some other carriers are there to simply say, we're willing to take on the higher risk groups. You're going to charge more, but we're willing to take those groups. The 3 R's say those carriers that are profitable through a variety of means have to take some of that profit to be put into a pool to pay for the carriers that take on the unprofitable business. So the profitable carriers have to give some of their profit to the higher risk carriers. You with me? Okay? That's very controversial. How would you like if that happened in your own business? That your company may be profitable, but you need to share some of that profit with your competitors who are not profitable. Probably wouldn't like that much, okay? That's what these 3 rules do. It was very interesting because back in 2010, I was asked to speak to a group of investment managers on Wall Street. And they all thought, when I went to speak with them, that by today, there would only be 3 or 4 carriers left in the market. They said it's just going to be the biggest because they've got the money and the resources to deal with compliance that the small carriers don't have, and they're just going to run them out of business. And I made a contrarian view. I said, no, that's actually not where I think it's going to go. I think that PPACA, through tools like this, is going to help keep those small and niche carriers afloat. And that is pretty much what we've seen. And we're going to be seeing more and more, because these market refinancing rules are just now coming into being. And so some of these smaller carriers will be able to stay around because of these rules. All right. I've got a specific slide here on Notice 2013-54, which I want to go into just a little bit. This is a rule that is there to attack, and this is just one example of such a rule. It is there to attack the concept of setting up an HRA to give money to employees to go out and buy individual coverage. What this rule basically says is if you give these employees this money, that plan will not be integrated. And when they buy that individual coverage, they won't be entitled to a subsidy. Why? Because that would be double dipping. They're getting tax advantage money because it's an HRA, and they're using that tax advantage money to buy an individual policy and also getting a subsidy, a tax subsidy, and that would be double dipping. The tax advantage money and the tax subsidy. This method will only work if the plan is integrated with the HRA. This gets to be very complex. When this rule first came out, there were a lot of articles that said HRAs are dead. And I disagree with that entirely. Integrated HRAs are going to be huge. And what do I mean by an integrated HRA? Once all these deductible limits come into being, particularly in the small group market, and say we're at that $2,000, $4,000 level, a lot of employers really want something with a higher deductible than that, would like to be self-funding at more than the $2,000 level. So what they can do is buy a policy that kicks in at $5,000, but integrate with an HRA that covers from 2 to 5. And since the HRA and the plan are integrated and together are one plan, we still meet the $2,000 deductible level. It's just we're taking 2 plans to cover that instead of 1. You with me on that a little bit? It's a complex deal, but I think you're going to be seeing a lot more in the next 12 months about integrated HRAs. I represent a lot of cafeteria plan TPAs, and I know they're hitting this very hard. 105H non-discrimination testing. This rule has the longest delay of any rule in the entire statute. This rule was supposed to go into effect in 2010. The regulators came in and said, we're not going to enforce it until we've issued regs. There are still no regs, okay? But you need to know what's coming. This is going to be critical for a lot of the industries in this part of the state because this is going to hit certain industries, and I'll talk about those. 105H is a non-discrimination statute that applies to self-funded plans. And it says a self-funded plan cannot discriminate in favor of highly compensated individuals. Can't provide a benefit to the highly comp that it doesn't apply or allow to the non-highly comped. And so some industries by nature tend to provide discriminatory benefits. They can't do that under 105H if they're self-funded plans, so what they have done is even if they're large enough to be self-funded, they go fully insured so that they can discriminate, because fully insured plans have been subject to state non-discrimination rules, which are a lot easier to get around than the federal non-discrimination rules. It's like we have to cover at least half the employees instead of all the employees. The new non-discrimination rule says that rules similar to 105H will apply to fully insured plans. Certain employers, this is going to be an enormous hit. Again, right now, we're expecting these regs next year. For 2015, probably start kicking in for 2016. What industries are going to be affected? This looks a lot like Branson. Restaurants, retail, and hospitality and entertainment. Why? Because there are a lot of seasonal workers, there are a lot of lower wage workers. In the restaurant industry, a lot of restaurants will cover the managers and assistant managers and owners, but not the other workers. They've gone fully insured because they could get around these rules at the time. But once these non-discrimination rules kick in, it's going to create real problems for these targeted industries. One of the questions we have when we want to see what's in the actual regs is, will the regs look at choice? Will the regs look at what choice does the employee have? Is there like a plan that's great that all the highway comp take, and then there's a POS plan, which, by the way, I'm not saying point of service, that's designed for the low-paid employees. Some of you will get that at the break if you didn't get it. Yeah. So is it discriminatory to offer two plans, but just so happens only the HCEs take the good plan, the others take the smaller plan? Hold on to that thought because we'll come back to it when we get into our discussion of pay or play. It will very much tie in with that discussion, so I'll be coming back to it. Let's talk about exchanges. It's been in the news a ton the past few weeks. We know that about 7.1 million as of now have signed up through the exchanges. This number's going to be going up a little bit because they don't have all the state numbers yet. There are three types of exchanges. You know this: state, federally facilitated, and state partnership. If a state doesn't have an exchange and the feds run it, that's called an FFE. That's what we've had in Missouri. A few states have a partnership exchange where the state is kind of in the visible position, but the exchange is actually run by the feds behind it. And I describe that as the state runs the retail store and the feds run the warehouse. Okay? So that's kind of what that is. There are also private exchanges, and you may hear about that. They really aren't exchanges. They're good, and they have a lot of good reasons for being there. But private exchanges really aren't anything new. Private exchanges are what we used to call a defined contribution plan. And they've just changed the title to kind of latch on to all the publicity around exchanges. But it's basically where a carrier or a broker or a TPA sets up a private exchange where the employer can say, we're going to give you $350 a month in a defined contribution, and here's our private exchange, and you can go and spend it however you want. You can spend it on plan for you at a high level. You can take a lower level plan and use some of that money for your dependents. You can do what you want, and that's what we call a private exchange. We've got a lot of clients setting up private exchanges. They have a lot of value, but again, they're not really new. They're a concept that's been around. As of now, the exchanges have been providing coverages to individual and small employers. Not really small employers, we'll get to that in a little bit. Small employers will probably come in more in 2015. They can be expanded to large employers in 2017. There's something called PSIP, which is almost out of business, which is a pre-existing condition insurance pool, which is a federal high-risk pool. Now that the exchanges are in play, all those high-risk individuals are being poured onto the exchanges. And I don't think those numbers are in that 7.1 million that's out now. Obviously, we've already talked about the single risk pool. All employers have to provide an exchange notice. The employers have to provide this notice to the employees as of last year. It simply says, here's our plan, but you also need to know that there's an exchange out there. And you may want to get policy on the exchange instead of through us because our plan is a POS. Maybe that helped you get the joke before. Okay. This applies to all the employees as of October of last year and new hires within 14 days of their hire. There are 2 model notices that have been published that employers can take and work off of. An interesting thing happened last fall, though. The DOL came out and said, well, you have to do it, but there's no penalty for not doing it. An employer said, then why would I do it? Because if there's no penalty for not doing it, why would I do it? So the actual, I think, number of employers that are actually doing this as required by the statute is much lower than the regulators wanted. Enrollment on the exchange, you know this, it just ended. There are some minor delays. The website crashed on Monday, so a lot of people who logged in have another, gosh, I can't remember, is it 30 days? Something like, I don't remember what the amount of delay is. If you tried to get in before March 31 and were unsuccessful, you have a little rollover period when you can still do it. You all know about special enrollments in your health plan. The same is true with the exchange. And there's also the annual enrollment, which will be shorter than it was for this year. There's also the shop exchange. And this is for small employers. And it's called shop. So employers which are, small employers which are 100 or under, unless the state says 50, have the ability to buy their group coverage on the exchange. And so it's a shop, except that this year there was only one policy. So you can shop as long as you like that one policy. I mean, it's kind of like going to Baskin Robbins. Instead of being 31 flavors, we now have vanilla and nothing else. Next year, there should be more options, or who knows, that could be delayed again, because I've not seen a lot of action going on with that. State-based exchanges, I won't go into a whole lot. The closest state-based exchange to here, boy, not many in this area. I've got a chart coming up on this next slide, which will show, I guess Illinois would be in there. HHS guidance has come out on the exchanges, but we're in a little bit of a breathing period right now. This is a chart of what types of exchanges the various states have. This came off the Commonwealth Fund website. There are 2 think tanks. Commonwealth Fund is a liberal think tank. The Heritage Fund is a conservative think tank. And they have lots and lots of good information. If you're looking for a place to get good information, as opposed to MSNBC or Fox, Commonwealth Fund and Heritage Fund are both terrific websites. Federally facilitated exchange, that's what we have in Missouri. So basically OPM runs that exchange. OPM is the Office of Personnel Management. And you look at it and go, well, why OPM? Why not HHS, right? Because HHS is the central agency in all of the ACA rules. So why OPM? Reason is they've been running an exchange for years, and that is the exchange for federal employees. They run the Federal Employee Health Benefit Plan, which is a plan that multiple carriers provide policies on, and so the federal employees get to go look at the market and figure out which one of the carriers they want to be with. Some are self-funded governmental plans and such. So OPM is running the FFEs because they have experience. They have literally 100 years of experience running an exchange plan, which is what FEHBP is. Each plan must have at least 2 plans. One has to be nonprofit. Again, it's overseen by OPM. The state partnership, I already talked about that. One of the key aspects of having the exchanges is the individual mandate. One of the things that has driven me completely crazy on the news is just about every report I've seen on local or national news is, if you don't buy a policy, you'll be subject to a $95 penalty. And people are going, big whoop. $95 is nothing. It's actually not $95. It's this table of the possible penalties. The part that rarely gets reported is it's a percentage of income, which is 1% in 2014 and increases in the years ahead. So somebody with a higher income will actually pay a pretty significant penalty. This penalty applies to applicable individuals without minimum essential coverage, and there are some exceptions. I'm not actually going to talk much about the individual mandate for the same reason I'm not talking about individual policies. We're really looking at the group stuff, so I'm going to hit on the employer pay or play provisions as opposed to the individual mandate. But if you really want to know about it, there are the numbers. Likewise, we have the premium tax credit. This premium tax credit applies to eligible individuals. It's income-based. They purchase a qualifying health plan through the exchange unless they're eligible for other minimum essential coverage. I've been hearing kind of stories about some low-paid employees and the kinds of subsidies they're getting on the exchange. Some employees or some individuals are basically getting coverage for free. We have a member of our church who got a very high-level metallic plan and is paying, with the subsidies, is paying $12 a month for that coverage on the exchange. These premium tax credits for some can be pretty valuable. They're not eligible for the tax credit if they're eligible for an employer plan and they actually enroll in the plan. Also, the affordability rule, again, I'm not going to talk about this a great deal now in the individual section. We're going to get into affordability from the employer standpoint in a little bit. The one thing I do want to talk about is there was a lot of question as to what the 9.5% applied to, and it talks about household income. Oh man, the community hated that. Employees don't want you to know what their spouse makes. They don't want you to know if they're moonlighting, okay? And so they don't want you to know what other income they have. And you know what the other side of that is? Those of you in HR, I don't think you want to ask, right? Do you really want to go to your employee and say, how much your husband making? Prove it. I've seen his car. I think it's more than that. Okay? So, they redefined household income to be the employee's W-2 wages. And you don't have to find out about the other family income. We have a minimum value test, which fails if the plan share of the total allowed cost of benefits is less than 60%. So in our metallic plans, that would be a bronze plan. Platinum's 90, gold is 80, silver is 70, bronze is 60%. Let's just look at a couple of questions, and then I think we'll get to our break right before pay or play. Partly because you're going to need coffee when we talk about pay or play. What's about, will employers move to the exchange? Well, you're going to look at, do they care based on what the current no coverage penalty is, or subsection A? What about the FICA tax savings on health plan premiums? Will employers say instead, we're just going to increase your salary and let you go buy something? What about business reasons? I've got a number of employers who wouldn't even consider getting rid of their plan because in some cases, they're in a highly competitive job market. Anybody in tech or software is fighting to get people. I just saw a report about an employer saying, and this was out in California, and my son's out at Stanford, and I read this when I was out there. They realize they get one interview. If they call these kids back for a second interview, they've already accepted another job. So they have to get all their interviewing done in that first interview because these kids are in such demand out there. Will exchanges work as intended? Well, what do you think? How has the first few months gone? Probably not. Will they work? Yeah. You know, their number of 7 million is pretty good, but it sure was a rocky road to get there. They came in where they had hoped to be with the original estimates, but it didn't go as smoothly as they had hoped. A lot of this has been dealt with delay. We're going to talk about that more later on because there's been a lot of controversy about the delay. A lot of statutes get delayed. This is nothing new. Is the workforce likely to qualify for subsidized coverage? What will be the cost and who will pay it? One final slide before I do my part of the break, and Randall looks like he's getting ready to come up and talk because he's staring at me really hard. Can a premium be paid through a cafeteria plan? And the answer is new, but it's really not, because it's the same rule that applied to other coverage outside the exchange before the exchanges. And that is, you can't pre-tax individual coverage through a cafeteria plan in most instances, okay? So if the exchange coverage being paid, the exchange premium being paid, if it's individual coverage, you can't pre-tax it through the cafeteria plan. If it's shop coverage, you can. Individual coverage, no. Shop coverage, yes. Why is it okay for shop coverage? Because that's a group health plan. Under the language of the ACA, shop coverage is looked at just the same as coverage that is being purchased by an employer in the private market. It is an employer group health plan, and therefore shop coverage also is an employer group health plan. Okay? My time for break, either Tom or Randall or Tim or somebody. I don't know, man. I was thinking this was going pretty well, but they're blocking my exit.
Well, before we go to break, I want to give the opportunity for some questions on what we've heard, so far. So, anybody brave enough to have me come over and stand by you?
Especially after you had
Okay.
a bad flight experience. Yeah.
Can any of the delays be retroactive?
Ah,
These delays that they're putting in there, can they actually then turn around and make everything retroactive back to when they originally wanted Hollister?
okay. I'm glad you rephrased the question because I was going to take it a different angle before. The question was, can these delays be retroactive? And in other words, I think what you're saying is, can we say we're not going to enforce 105H or non-discrim? We'll come out with the regs in 2015, but it applies back to 2013. They can't do that. They're not going to do that. They've announced that. There have been some that I would call retroactive because they didn't get around to it until later. And they're saying, the common thing we're hearing about delays is we won't enforce the statutory rule until we come out with regs. So even though, like with the non-discrim, the statute said these rules kicked in 2010, the regulators are saying we're not going to enforce it till 2015 if that's when we come out with the regs. So they are being fair about that, I think.
You were talking about the fact that there was a delay or repeal of sorts on the deductible limits for small groups. That's effective for 2014, not 2015.
Correct.
Have
Right.
they, is it being removed or delayed?
Delayed,
Okay.
potentially removed. We received notice that they're going to come out with this rule, but we haven't seen the rule yet.
Okay, so there's no.
This was like a pre-announcement.
Okay, so there's no specifics yet around.
No specifics yet.
Whether it would just revert to the standard total out of pocket.
Well, what it's saying is if the press release is correct, what it'll mean was it won't be effective this year for small groups, but next year it will at the 2,000, 4,000
Okay,
level.
thank you.
But again, we haven't read the exact regs yet. And I'll have a couple things like that in our next section.